Hello, welcome everyone. It is a great pleasure to be here. Thank you for the very kind introduction. Nima, Shima, huge congratulations on your great leadership in putting this together. This is an amazing event and I'm very happy to discuss for the next 15 minutes with you serrated polyps. So we've learned a lot about the optical diagnosis classification, so let's spend this 15 minutes on actually getting to know what are serrated lesions, how we are going to manage them. These are my disclosures. So for this talk I divided this into three main parts. For the first part I would like to discuss with you importance of those lesions. Do we actually have to care about serrated lesions in colon? So this is something that we will start from. Then we will practice a bit of recognitions of those lesions because unfortunately it gets very, very tricky to detect those lesions in colon. And then we will discuss at the end the treatment of those lesions, how to manage them the best. Okay, so importance. Do we have to care about serrated lesions? Let's compare them with something that we all very familiar with. So adenomas. We know that adenomas are precursor of colorectal cancer is 70%. They're always dysplastic by definition. They have low-grade dysplasia, high-grade dysplasia, and they have different subtypes like tubular villus and tubulovillus. So serrated polyps are just a different second subclass of the polyps in a colon. And actually they are precursor of colorectal cancer up to 30%. So it means that 30% of all colorectal cancer that we will diagnose in our clinical practice, they actually grow not from adenoma, but from serrated lesions. So they, majority of them, they don't have dysplasia, but they are premalignant lesions. They are divided into hyperplastic polyps, sessile serrated polyps, and traditional serrated adenomas, and I will talk about them in detail very, very soon. And again, I just wanted to show you this results from the big population-based analysis from Netherlands. When actually they assessed, they asked this question: if the endoscopist has high detection of adenomas but low detection of serrated lesions, does the risk of post-colonoscopy cancer is high in those patients or not? And you can see, like, down right square, actually hazard ratio for those who are very good in detecting adenoma, so they have higher adenoma detection rate, but they have low detection of serrated lesions. Their patients have higher risk of post-colonoscopy colorectal cancer, so the cancer after colonoscopy which was negative, no lesions were detected. So actually it only emphasizes why it is important to be aware and be able to detect those lesions. Why serrated polyps are called serrated? I'm sure many of us ask those questions because their morphological look doesn't look serrated at all. So serrated name comes from the histopathological appearance, and when we just compare sessile lesion with tubular adenoma, you can appreciate those serrated like tooth surface, and this is why they're called serrated. As you can see, it's compared with this shape of the knife. Okay, so crash course in epidemiology of serrated lesions. So what we are dealing with. I think that this is very interesting statistics that the prevalence in men and women is basically the same. Contrary to adenoma, when the male dominance in adenomatous lesions is well established here. This is, as for men, as for women, serrated lesions are the same, and this actually can explain why women can have higher rate of proximal post-colonoscopy colorectal cancer, because this prevalence is I think underestimated in women. Okay, the dysplastic lesions, we have around 13% of all of them will be dysplastic, so will carry some precancerous potential. Another thing that I think is very important, they're like mushrooms. If you find one, there is a very high probability that you will find the second one or the third one, because up to 30% of them are diagnosed in more than one number. And also I think we should be aware that this is not an exclusive diagnosis. So we can have a serrated lesion and adenoma in one examination in one colon, and actually you can see bottom right circle, 50% of patients have synchronous adenomas, and serrated lesions. Okay, so how to recognize those lesions? We will divide them into hyperplastic polyps, which are the most prevalent. They usually in a distant colon. They're small and they don't have premalignant potential. So we won't discuss them because we don't actually, if they're less than 5 millimeters and they are in distal colon, we don't have to remove them. We have sessile serrated lesions, up to 10% of polyps in the colon. They are a bit larger and their morphology is usually flat or sessile. That's why they're called sessile serrated lesion. And they are usually the vast majority of them are diagnosed in a proximal colon. There is also some mixed type called traditional serrated adenoma. It's a mix of serrated and adenomatous lesion. This is very low in prevalence, less than 1%. So we don't have to focus on them that much. I think our attention should be really focused on this group in the middle, as this is the highest prevalence and some cancerous potential. Okay, so what are endoscopic features of serrated lesions? So there are some established features that will help us to recognize those lesions. First, they have clouded surface. So this is actually developed this feature by Dutch people from the Netherlands. I think they have their weather really, predisposed them to make this comparison. But actually, when you look and when you delineate those lesions in the colon, you can really appreciate that they look like clouds. The second thing is they are very indistinctive. They are very subtle. Diagnosis of serrated lesion is very difficult, and you can see that this is very difficult to appreciate this lesion on the white light. It gets a bit easier in narrowband imaging, and so this is tip number 1, use narrowband imaging when you assess the colon or any other advanced modality, because you can actually increase your chance for detecting this subtle lesion. They have irregular shape, and this irregular shape stems from not from the border, which is cloud-shaped, but their surface is also irregular. So this is something very characteristic for them. And they have dark spots inside the crypts. This is something that you cannot appreciate in adenomas. You can see those red arrows. They're indicating the dark spots. This is very characteristic features for serrated lesions. They also, because of their irregular surface, they tend to have this mucosal cap. So this is just the stool debris or just the mucus, which stays on the surface. This is very helpful because when we assessing the colon, we can actually spot a bit of mucus, that's mucosal cap. So we should go there and examine this place better, because this might be serrated lesion which is covered, which irregular surface actually is accumulating this mucus. So how to differentiate, I told you that this is very important to differentiate between hyperplastic polyp and sessile lesions, because sessile lesions, they're dangerous, they have cancerous potential, and hyperplastic polyps, we can actually leave them in a colon. So there is this WASP classification, which is very helpful to differentiate those two types of lesions, and I want to go walk you through this. So we heard in a previous talk about NICE classification. So serrated lesions, they belong to NICE type 1 classification. So as a reminder, their color is just the same or brighter as a background. They have no visible vessels, or the vessels are just isolated on their surface, and the surface itself has lack of any characteristic pattern, or we can see those characteristic dark spots that I said. So if we are dealing with NICE type 1 lesion, we have to ask ourselves whether we can see at least 2 of those 4 features that we just discussed. So clouded surface, indistinctive border, irregular shape, or dark spots in the crypts. And if yes, this is a sessile serrated lesion, and if not, this is hyperplastic polyp. I think this is very important to spend some time to actually go through this, because it's very helpful in optical diagnosis and will guide us in our treatment and management decision. Okay, so let's practice a bit. Let's appreciate how does it look like in a real life. So actually here at 6 o'clock there is a huge. There is a large sessile lesion. I think it's almost 20-25% of the circumference of the colon, and you can see that it's very difficult to appreciate this on a first sight. We need to spend some time, and the longer we look, we actually see that this lesion is subtle, but it's not small. What is helpful, as I previously said, it's narrow band imaging that we will appreciate in a second. And here you can see this when we switch on the contrast, we can actually delineate lesion, and you can see this dotted line showed us this. For the sake of time, I can't go through the entire movie that I prepared, but I recommend you to spend some time to look for those features that we discussed: clouded surface, those irregular surface, and dark spots. Okay, so now when we can recognize those lesions, how we treat them, we have to take into account three major things. So technical feasibility, risk of recurrence, and complications when we are thinking about which method will we use. Basically, removal of serrated lesions follow conventional polypectomy. So for the lesions smaller than one centimeter, we should always go for cold polypectomy, and we have a body of evidence to support that this is the best way to go. One technical remark here: this technique is not very elegant. Contrary to the hot snare polypectomy, when we switch diathermy on, we have this elegant rim of mucosa, this elegant resection. In cold snare polypectomy, sometimes we have to work on this a bit more, and even we sometimes have to pull the snare into the scope to achieve this cold resection. And what is more, the effect after the resection, it's not always very elegant and beautiful as we can appreciate after hot snare polypectomy. But don't get discouraged. This is the best way to go with those small polyps. So what about larger lesions? What about lesions that are larger than 1 centimeters. So there is a helpful meta-analysis, just recent, more than 2,000 lesions that actually compared cold and hot polypectomy in larger serrated lesions. So basically the overall success rate was 100%, and I want to draw your attention for those statistics for adverse events rate, and you can actually see that although those statistics are not significant, but you can see that there is a tendency for hot polypectomy to be associated with the higher adverse events rate, and for the recurrence rate as well, and this was statistically significant. So hot EMR for those lesions associated with a higher recurrence rate. So I think this is actually something that we have to keep in mind, that cold snare polypectomy here could be beneficial. What about those large lesions? When we think about EMR, there is analysis of over than 500 lesions bigger than 2 centimeters, and again comparison between cold snare and hot snare EMR showed that cold snare was associated with significantly lower adverse event rates, especially for post EMR bleeding, but also for deep mural injury. So I think that this tells us and trends us towards cold polypectomy. So some concept in cold snaring practical tips. I think, of course, this applies to any conventional polypectomy, cold or hot, doesn't matter, that we need to really be very careful when inspecting colon and we suspect serrated lesions. As we discussed before, they are very, very subtle, and we have to spend some time to actually find the lesion, delineate lesion, and plan the resection accordingly. what is important, I think the lifting is very helpful in those lesions. It allows us to create a surface in a submucosa, so it will pull a muscle layer away from the mucosa and will actually make our resection easier, but also it really helps in a delineation of the lesion, and you could see on this movie that after the injection, delineation was really was significantly easier. What is also a practical tip that I could give you today is there is a trend now to use dedicated cold snares for cold snare polypectomy, and of course this is very useful, but not always available. So if you don't have dedicated cold snare polypectomy, you can use just normal conventional snare, but make sure that it's small and stiff. Take small bites with the small 15 or 10 millimeter snare, and you will allow for a very nice cold snare polypectomy. Ensure a wide rim of normal mucosa. This is very important, and I think this concept actually allows us for the very low recurrence rate after cold polypectomy in serrated lesions. And as I said before, don't get discouraged with the effect and with the fact that this is not a very elegant technique. It's very effective, and I think that's the most important thing. You can appreciate here a large laterally spreading a serrated lesion removed completely with cold snare, and you can see the beautiful effect on the down right square with a beautiful scar. So just to summarize, I hope that we can all now appreciate the importance of serrated lesions in colon. We definitely know how to recognize them, and the tip practical to manage is to seek and destroy them completely. Thank you very much.